Hi, I am Dr. Nalla Perumal from Chennai. I am a consultant diabetologist practicing at Motherhood TTK Road, Alwarpet. My focus today is pregnancy diabetes. So when it comes to pregnancy diabetes, women can have pre-existing diabetes and they may be planning to conceive, or they are apparently normal but they have developed diabetes during pregnancy, that is called gestational diabetes. In this presentation, I will cover pre-existing diabetes, that is diabetes present prior to pregnancy itself. So when it comes to diabetes, it is a largely asymptomatic, symptom-less problem. So most of the persons with diabetes won't even know that they have got diabetes. Only a small chunk of people will have symptoms. And the problem in pregnancy is more and more young people are getting affected with diabetes, and when it comes to women, it is exactly their reproductive age. So when somebody develops diabetes at say 50-60 years, it doesn't matter as far as pregnancy is concerned. But when diabetes starts striking younger people, say a woman at 22-24 years getting diabetes, then she has to undergo the entire pregnancy with the background metabolic problem of diabetes. And unfortunately, at that age, nobody will be getting screened, because since there are no symptoms, many of them get diagnosed when they get diagnosed with pregnancy itself. That means first consultation with the gynaecologist, say 6 to 8 weeks of pregnancy, the routine screening tests have been done, and a significant number of people get diagnosed with pre-existing diabetes. So before going into the details, I have to tell you how we diagnose diabetes in the first place. So we can diagnose diabetes through 2-3 tests. One is the fasting and postprandial plasma glucose values. So fasting, if it is more than 126 milligrams on 2 occasions, or postprandial after your breakfast or after a 75 grams glucose load, if it is crossing 200 milligrams per deciliter, then we can diagnose diabetes. Or if we take HbA1c criteria, the 3 months average, if it is 6.5% or above, then it is diabetes. Many people fall between 5.7 to 6.4% HbA1c, that is at risk for diabetes or pre-diabetic condition. So even if a woman has got a pre-diabetic condition, say 5.7 to 6.4 HbA1c, as soon as they become pregnant, there are hormonal changes which happen in the body. So because of the placenta, new hormones are coming in that increase the insulin resistance, and the sugar level starts going up faster. The problem in diabetes, especially during first trimester, that is first 3 months, is the baby is forming the organs. So by 6 weeks the heart beat appears and the brain is almost formed, and by between 5 to 8 weeks the kidneys are formed. So many times women get diagnosed with diabetes when they are at around 9 to 10 weeks of pregnancy, because that's the time when the investigation happened and they consult the gynecologist. By the time the organogenesis has happened. So when somebody has got diabetes, if they know that they have got diabetes, especially if they want to conceive, the first priority is to control diabetes with safer medications before even they plan to conceive. So it should be always a planned conception. So they have to consult a diabetologist or endocrinologist to control their diabetes with appropriate medications. For example, if they are on unapproved drugs, say sulfonylureas or drugs like GLP-1 receptor analogs, DPP-4 inhibitors or SGLT2 inhibitors, all these drugs are contraindicated in pregnancy. So by the time a woman comes to know that she is pregnant, the fetus got exposed to all the unapproved drugs. So diabetes should be controlled well ahead of pregnancy. The ideal time to control the appropriate specialist is almost 3 to 4 months before you want to conceive. Then it gives the doctor a time window to control it properly so that the fetus is safe. So if it is a planned conception, then the doctor will be starting the meal plan, appropriate medication, control the sugars to the targeted range, and they'll be giving you a supplement of folic acid also, because in people with diabetes there is a folic acid deficiency which is very important for the baby's brain growth. So the folic acid supplementation should happen or should start months ahead of pregnancy. So, and then the problem of complications. Sometimes even asymptomatic people with diabetes can have microvascular complications as a pre-existing problem. So they need to get screened for the presence of microvascular complication before planning pregnancy. So one simple test is urine microalbumin, which can tell us about the renal function. And the another important advice is to go to a good ophthalmologist to have a dilated eye examination to rule out pre-existing diabetic retinopathy. So these are the basic things. One is screening for microvascular complication, changing to appropriate medications which is safe for the fetus, and then achieving good control before pregnancy itself, all play a vital role in keeping the baby safe. Once all this is done and the conception happens at a level which is desired, then the baby is safe, as safe as any other baby. Like even in non-diabetic mothers, the outcome is very good. So similar outcomes can be achieved in people with pre-existing diabetes. So during pregnancy, as the placenta starts secreting hormones, there will be progressive insulin resistance. So all pre-existing diabetic women will be on insulin and probably on a dose of metformin, and the insulin doses will be progressively adjusted upwards to keep the baby safe. If the sugars are going up during pregnancy and if the doctor increases the insulin dose, it is not your fault. It is the physiology of pregnancy, wherein if a woman requires insulin during pregnancy, in all probability there will be increased requirements as the pregnancy advances. And there should be a close coordination between the diabetologist or endocrinologist and the gynecologist, so that all steps can be planned perfectly. For example, when the scan report comes, so it gives us a clue whether diabetes is under control or not. Apart from the SMBG records, HbA1c, still we have got other means of ascertaining whether the diabetes is under control, like the amniotic fluid index, the fluid around the baby, and the growth profile of the baby. Suppose abdominal circumference is crossing 95th percentile, then probably the baby is growing big, probably due to suboptimal control of diabetes. So all these factors will be taken into account whenever a consultation happens. And when it comes to monitoring, all women with pre-existing diabetes should have a glucometer, and then they start testing according to a structured monitoring protocol. And they will be on multiple doses of insulin to control sugars everywhere, because when it comes to the baby gets exposed all 3 times when the mother eats. It's not about controlling only the morning times, so we need to look into the lunch, post dinner, all the values need to be controlled properly, and at the same time we need to keep the mother safe from hypoglycemic episodes. So when delivery comes closer, then there will be a closer interaction between the gynecologist and the diabetologist, because in pre-existing diabetic women, generally we don't wait till the end of or till the expected date of delivery, because last 10 days to 2 weeks there could be a fetal heart rate variability, even if somebody has got good control. So when the baby is grown well and the maturity level is reached, then the appropriate time will be set for the delivery. So that means in pre-existing diabetic patients, the delivery will happen little ahead of the expected date of delivery, and the mode of delivery will be decided by the gynecologist. They will be taking into other factors into account. And post-delivery, the insulin requirement comes down drastically. Some people may not require insulin at all, some people require only small dose of metformin, and pre-existing diabetic women will continue to have diabetes, but they have to keep a watch on their sugars and keep it under good control for their future. And as far as the baby is concerned, the mother has to feed the baby, because this mother has got a pre-existing diabetes, probably because of the family history or something. So feeding the baby with mother's milk definitely protects the baby, and it is one probable protective mechanism against future diabetes in the baby, for the baby when the baby grows into an adult. So breastfeeding is strongly advocated for mothers with diabetes, and then the baby will be watched, especially during the first 24 hours, for symptoms of low sugars and other problems. So pre-existing diabetes can be of like type 1 diabetes or type 2 diabetes. Whatever type of diabetes you have to plan your pregnancy perfectly, and conception should happen under medical guidance when your diabetes is under good control with appropriate medications. Thank you.